Hello, my name is Lalisa. I am a PGY2 internal medicine resident at Mercy Hospital, Portsmouth. Today, I am going to discuss about rhinoscleroma and two cases of it presenting to our hospital. Case 1 is of a 34-year-old man who presented with chronic, progressively worsening nasal congestion, sinus pressure, and shortness of breath. He reports a remote history of vocal cord polypectomy and a recent diagnosis of obstructive sleep apnea. Patient moved to the United States from Mexico as a teenager and has never visited Mexico since then. Physical exam shows narrowed vestibules bilaterally and enlarged tonsils. These findings were confirmed on flexible nasopharyngeal laryngoscopy. Patient underwent tonsillectomy. Nasal endoscopy demonstrated bilateral sclerotic appearing lesions near the head of the inferior turbinate which were biopsied. Biopsies reported inflammatory infiltrates with features of rhinoscleroma as seen in Figure 1. Cultures grew 2 plus Klebsiella pneumoniae subspecies Rhinoscleromatis, methicillin-sensitive Staphylococcus aureus, and a few Streptococcus G group. He was started on a 3-month course of ciprofloxacin 500 mg twice daily. Patient was lost to follow-up. Case 2 is of a 24-year-old woman who presented with nasal congestion predominantly on the right that started 3 years ago. This was initially managed as allergic rhinitis with no relief. Over the next 2.5 years, she reached a point of using oxymetazoline nasal spray daily. She reports foul odor and taste in her mouth. Her only other significant medical history is of allergic rhinitis as a child. She was born and lives in Arkansas. Her parents were natives of El Salvador and Mexico. Patient has visited Mexico 4 times in her life. She lived in Mexico for 4 months 10 years ago. Examination reveals mass-like lesion of the right mid-anterior nasal septum with crusting redemonstrated on nasal endoscopy. CT scan revealed plaque-like enhancement lesions as seen in Figure 2 and Figure 3. Endoscopic biopsies were obtained, followed by lysis of intranasal synechia and reconstitution of the nasal airway. Biopsies report granulation tissue with inflammatory changes and foamy macrophages as seen in Figure 4. Cultures grew 2 plus Klebsiella rhinoscleromatis, methicillin-sensitive Staphylococcus aureus, and few coagulase-negative staphylococcal species. She was also started on 3-month course of ciprofloxacin, and she was lost to follow-up. Rhinoscleroma is a global disease endemic to Africa, Central America, South America, Europe, and Asia. It is a chronic granulomatous disease of the upper airways. It progresses in 3 stages: a catarrhal stage, a granulomatous or proliferative stage, and a sclerotic stage. Catarrhal stage presents as rhinorrhea and sinusitis. Granulomatous stage involves proliferation of the tissue with granuloma formation resulting in tissue destruction, nasal obstruction, foul discharge, and sometimes epistaxis. The sclerotic phase causes extensive airway scarring. The last 2 stages can result in permanent nasal deformity. Histopathology is characterized by foamy macrophages in an inflammatory backdrop. Miculic cells, that is, foamy macrophages showing intracellular organisms specific to rhinoscleroma, are only seen in half the patients. Treatment involves long-term antibiotics in combination with surgical debridement. Tetracyclines and streptomycin have been used previously. Ciprofloxacin or other quinolones have been preferred after their efficacy has been proven according to the Mayo Clinic study in 1993. Treatment duration extends anywhere from 2 months to 6 months and sometimes years. Relapse is common and hence long-term follow-up is recommended. Though rhinoscleroma is not endemic and rarely seen in our region, we have encountered 2 cases in the past 1 year which throws light on the increasing incidence of the disease in the United States, including Arkansas. Therefore, we stress the importance of increased awareness and high clinical suspicion of this rare disease. Thank you.